Good morning, respected faculty, respected chairpersons, dear coordinators, Dr. Limadan and Dr. Neha Mehra, and all the delegates. We are here with the next session of pediatric rheumatology, that is juvenile dermatomyositis by Dr. AVINASH Sharma. We have eminent chairpersons, Dr. Ramesh Bajania and Dr. B. Nandesh sir. I'll just introduce. Dr. Ramesh Bajania sir is National Vice President West Zone of Central IAP for year 2025. He has been EB member of Central IAP, and he has a great work on the environmental health and climate changes. And he is a member of the International Committee of Pediatric Association regarding this. And he is also member of IPA and Secretary of Environmental and Child Health Group in 2019 and 21. He is the organizing chairperson of the PED-NV-CON held in 2016, 2021, and 23. He is working great on the lead poisoning also, as he is the member of the India Action Group on lead poisoning. And he is also Indian College of Pediatrics Evaluation and Examination member in 2024. And he has been the national trainer for various IAP action modules like Covinude, Point, NTP, National Tuberculosis Elimination Program, Nurturing Care and Early Child Development, and I lead Diagnostic Dilemmas, Basic NRP. We welcome Dr. Ramesh Bajania, sir. I request him to please say a few words.
Thank you, Dr. Ajay Gupta, sir. Thank you for this opportunity. First of all, let me congratulate you and Indian Academy of Pediatrics Delhi and all stakeholders for creating such a useful module. You know, now with the infectious diseases being vanished, we are coming across so many other subspecialty and the other spectrum of disorders like developmental pediatrics, adolescents, rheumatology. And I'm very sure that with this endeavor, common pediatrician, our colleagues, they will be sensitized to at least sense that there could be a rheumatology case in this. And we also recently held a rheumatology webinar at our Gujarat Pediatrician WhatsApp group. And I really appreciate that you are focusing on the areas less recognized and less appreciated by common colleagues. So wish you all the best for your future endeavors also. And my best wishes to you and the Delhi team for this. Thank you so much for this opportunity.
Thank you, Dr. Bajania, sir. We have Dr. B. Nandesh, sir. He's the Central IPEB member from Karnataka, and he was the national coordinator of all action plans in 2024. We welcome Dr. B. Nandesh, sir. I request him to please say a few words.
Very good morning to all. Very good morning to Dr. Ramesh Bajania, sir, Vice President, West Zone. Very good morning to Dr. Ajay Kumar Gupta and our well-known speaker today, Dr. AVINASH Sharma, and all the dignitaries present here and all the viewers. I congratulate the Indian Academy of Pediatrics Delhi branch for organizing such a wonderful academic event and inviting all the participants for sharing the knowledge on rheumatology. Congratulations you and wish you all the best, sir. And I thank the team led by Dr. Ajay Kumar Gupta, sir, for inviting us to chair the session and participate in the academic event. Wish you all the best in your endeavor to spread the message of academics, pediatrics through your events, academic events. Thank you very much.
Thank you, sir. I request you to please introduce the speaker also.
Sir, it is my honor to introduce Dr. AVINASH Sharma. He is a DM in Pediatric Clinical Immunology and Rheumatology. Sir is an associate professor at Dr. Rajendra Prasad Medical College, Tanda, Kangra, Himachal Pradesh. He is known for his clinical acumen in immunology and rheumatology. So he has done wonderful work in this field and has 30 publications national and international journals to his credit. So sir has keen interest in clinical aspects of Kawasaki disease and well known in immunology chapters. I request Dr. Avinash Sharma sir to kindly go ahead with today's topic on juvenile dermatitis. Welcome you, sir.
Thank you, sir. Thank you. Good morning and namaskar to all. First of all, I would like to thank the organizers for providing me this wonderful opportunity to be a part of this exciting program. I would like to thank Dr. Ajay, Dr. Anu. I would also like to thank all the previous speakers who have been, esteemed fellows, colleagues, Dr. Anu, Dr. Sujata, Dr. Manjari, Dr. Narendra, Dr. Neha, Dr. Pratap, who led us to such interesting discussions and took us through the interesting cases. And I'm sure that all those who are attending must have benefited from those discussions. I would like to thank the chairpersons for this kind introduction. And I think I should begin sharing my screen now.
Yes, sir. Please go ahead, sir.
Okay. So today's discussion is on another interesting pediatric rheumatological disorder, not so common, not as common as the conditions which were discussed in the previous sessions like juvenile arthritis or systemic lupus erythematosus or various kinds of vasculitis, but it is an extremely important rheumatological disorder to understand, to know about, so that these children are picked up timely, managed accordingly, and very important complications can be prevented in them. It is not as common as other rheumatological disorders, but in fact, it is the commonest childhood inflammatory myopathy. As the name suggests, juvenile dermatomyositis. So it has some very characteristic clinical features in terms of dermatological manifestations, as we'll see through the discussion. So there are characteristic dermatological manifestations along with muscular or musculoskeletal manifestations, identification of which help us pick up these disorders or diagnose this group of disorders. It is characterized by a systemic inflammation. So it is not only inflammation of muscles, but rather it has been shown to be a systemic perivascular inflammation, which is the initial event. So the vessels get inflamed, necrosed, and finally the muscles get involved. So it is a systemic perivascular inflammation. To understand the disease better, how do we approach such cases? How do we diagnose and manage them? Like the previous speakers, I'll take all of us through very few cases, which will help us understand the disease better. So coming on to the first case, this is the institute where I work in Himachal Pradesh, Dr. Rajendra Prasad Government Medical College. So moving on to the first case, she is a young girl, a 5-year-old girl, born to non-consanguineous parents. The parents brought the child with a history of rash, which they noticed about 8 months back, predominantly over face and hands. A few months later, about 6 months later, she started having fever and gradually progressing inability to stand from sitting position, which was there for last 2.5 months. In the past, there has been nothing significant. Otherwise, she was developing normally, and no other significant history could be obtained from the attendants. So when asked further, it was noted that the rash which the parents noted or reported was a kind of erythematous rash over cheeks that aggravated on exposure to sunlight. The parents also noticed periorbital swelling at some times, and the rash over hands was in the form of reddish colored raised lesions over knuckles. This is what the parents told. Weakness, as already stated, was insidious in onset, however, was progressively increasing throughout this course. There was difficulty in walking upstairs and downstairs. There was difficulty in lifting arms above head. And parents also reported that she was complaining of pain in different muscle groups, especially pain in thighs, and often she did not allow her to be touched. So looking at this history, I'm sure that the residents who are attending this are able to make out that this is an insidious onset weakness and predominantly the proximal muscle weakness, along with some rash and pain in thighs. So it gives some kind of pattern. When examined, we could appreciate, because of the issues of privacy of the patient, the pictures that I used, I tried to hide the features, but we can appreciate the erythematous rash over cheeks, a rash over eyelids, a linear kind of violaceous rash over the upper eyelids, and maculopapular raised erythematous lesions over interphalangeal joints. So this was noted when the patient reported to us. Other CNS examination in the form of mental functions, cranial nerves were normal. The bulk was essentially normal and symmetrical. Tone was also normal. When palpated, the patient again complained of tenderness over thighs, calves, and arms. So pain and tenderness was another feature. On further examination, she was not able to stand from sitting position unaided. So it was, very evident that she had proximal muscle weakness. Power was tested and power was reduced in the proximal muscle groups, that is the hip joint and shoulder joint. Deep tendon reflexes, again, one should try to remember this. One should try to look at this, that deep tendon reflexes are normal in this case. Superficial reflexes were also normal. No abnormality detected in sensory system or the cerebellar system examination was also normal. So essentially, we have a young girl, 5 years old girl, with a history of fever, a kind of longish duration of fever, 2.5 months, and symptoms lasting for more than 6 months. So the total duration is 8 months. So a young girl presenting with history of fever, rash, and proximal muscle weakness, on examination found to have these characteristic rash, which is known as heliotrope rash. The rash which was seen on eyelids is known as heliotrope rash, and the rash which was seen over the interphalangeal joints is known as the Gottron papules. On examination, she also had positive Gower sign, muscle tenderness with intact reflexes. So this is all that we need to diagnose a case of what is known as juvenile dermatomyositis. Essentially, it is a clinical diagnosis. As we have been discussing in the previous sessions as well, most of the rheumatological disorders, we diagnose them based on the clinical signs. And it is often only a good history and examination that help us most in making such diagnosis. So if we get this characteristic dermatological features in form of Gottron papule, heliotrope rash, along with symmetrical proximal muscle weakness, then the diagnosis is in front of us, and it is inflammatory myopathy, juvenile dermatomyositis. I can recall few patients who were diagnosed as having some neurological disorder, even LGBS, and finally diagnosed to have juvenile dermatomyositis. So we must remember that juvenile dermatomyositis is a chronic disease. Like in this case, we saw the history lasting for a few months. And there are certain features like dermatological features, intact deep tendon reflexes, which help us make the diagnosis of juvenile dermatomyositis. In fact, there are classification criteria. Again, as we have been seeing, there are classification criteria for almost all kinds of rheumatological disorders, which are used for classification. So classification criteria for juvenile dermatomyositis were given way back in 1975 by Bohan and Peter. Essentially, the criteria remains same, but different group of workers have tried to give new set of criteria with the newer modalities of diagnosis being available. In Bohan and Peter criteria, they're essentially very common sense kind of criteria. If we have classic rash in the form of heliotrope rash and Gottron papules, plus any three of the following, which is proximal muscle weakness, muscle enzyme elevation, EMG, that is electromyographic changes. There are some peculiar and specific changes which have been reported for juvenile dermatomyositis, and characteristic findings on muscle biopsy. So if any three of them are present, we call it definite juvenile dermatomyositis. If two of them are present, then probable. If one of them is present, possible. But these are again classification criteria, and there are some issues with this criteria as with any other rheumatological criteria. And now we have some newer tools to diagnose juvenile dermatomyositis, and often we do not require EMG and muscle biopsy to prove the diagnosis of juvenile dermatomyositis. If we try to understand, it is very logical and simple to understand that if a child with proximal muscle weakness, symmetrical proximal muscle weakness comes to us and he has those characteristic dermatological signs in form of Gottron papules and heliotrope rash, then the diagnosis is right there. We do not need muscle biopsy or EMG to prove the diagnosis of juvenile dermatomyositis if we have characteristic dermatological findings and proximal muscle weakness. The other issue with muscle biopsy and EMG is that both are invasive procedures. We need to insert some needles for an EMG. We need to get the specimen for doing a biopsy. And moreover, the involvement of muscle in inflammatory myopathies or juvenile dermatomyositis is patchy. So involvement is patchy. If we take the biopsy specimen, we may miss the part which is involved. So we may miss the diagnosis even on biopsy. So these are few issues with these criteria, and therefore people don't often use muscle biopsy and EMG to prove that this is juvenile dermatomyositis. There are specific situations where it may help. And now we have some newer tools that help us in diagnosis, and very important, relatively easily available is MRI, which is done whenever we suspect a case of juvenile dermatomyositis. And there are some things called myositis specific autoantibodies, and there are also myositis associated autoantibodies. So there are two groups of autoantibodies, myositis specific and myositis associated autoantibodies. These help us in making a diagnosis. So how do we diagnose then juvenile dermatomyositis? If there is a characteristic rash in presence of symmetrical proximal muscle weakness with elevated muscle enzymes, characteristic MRI findings, and presence of myositis specific autoantibodies. We look for them, myositis specific autoantibodies. We may not find all the features in all patients, but this is essentially what we need to diagnose a case of juvenile dermatomyositis. Characteristic clinical findings, elevated muscle enzymes, MRI, and myositis specific autoantibodies. Coming to them one by one with the help of our case, what we did with her, we did the very basic of investigations in which ESR was elevated. If you look at muscle enzymes, creatine kinase, LDH, and the aminotransferases are elevated. How do they help the muscle enzymes? So muscle enzymes are nearly always elevated in patients who have an active disease. So situations where the disease is very long-standing, we sometimes call it burnt out disease. Disease has been there for very long and it is not active now. So these are situations where you may not find the muscle enzymes to be elevated. But in active disease, nearly all the patients will have elevated muscle enzymes. We need to understand some things. We need to remember some things, like very commonly used muscle enzyme is creatine kinase, but it does not always correlate with disease activity, but it responds early to treatment. So we cannot use it to measure, to monitor disease activity. LDH, however, correlates with disease activity, but is last to respond to treatment. A combination of AST and LDH is said to be best to predict disease flares. So we need to remember that there are muscle enzymes which help us make diagnosis of juvenile dermatomyositis, and we expect that these muscle enzymes will be elevated in active disease. So we have a patient with characteristic clinical features. we do the neurological examination, we get the muscle enzymes done, they are elevated, and the diagnosis is more certain. Now, role of MRI, imaging. The most commonly used muscle group or most commonly used area which is imaged by using MRI is thighs. So we do an MRI thigh and we look for symmetric T2 or stir signal hyperintensities along with subcutaneous edema. The findings are diffuse. So these are characteristic findings on MRI. If you find them symmetric, diffuse stir signal hyperintensities and subcutaneous edema, these are suggestive of inflammatory myopathy. In our patient, we also found post-contrast enhancement in anterior medial posterior compartments of both thighs and gluteus muscles, which again is suggestive of inflammatory myopathy. Another interesting and important modality, which is often used when we diagnose and follow patients of juvenile dermatomyositis, is nail fold capillaroscopy. Can easily be done. Dermatologists use it very often to look at various conditions. They looking at nail fold capillaroscopy is not specific or is not limited to juvenile dermatomyositis, but many systemic vasculopathies. So if we find abnormalities in nail fold capillaries, abnormalities in the form of dilated capillary loops or dropouts or microhemorrhages, these are signs suggestive of an active disease. So to monitor disease activities, to monitor the disease, the patients, to follow these patients, it is an easily available tool, and with a little bit of training, one can say look at the nail fold capillaries and find if the disease is active. So along with MRI, muscle enzymes, nail fold capillaroscopy is also a useful tool. And now, though the MRI does not find a place in the initial criteria, MRI has become an important tool for diagnosis, and it is almost done in every patient in whom we suspect or diagnose juvenile dermatomyositis. When we investigated our patient, MRI I've already discussed. Further investigated, the patient was found to have ANA positivity. We have seen in many pediatric rheumatological conditions, the most common being SLE, in which ANA has got an important role. But we have also seen that in various kinds of arthritis, ANA has got a very definite role. So ANA, when done in this patient, was positive, 3+ homogeneous. Anti-dsDNA, which is specific for SLE, was done, which is negative. And another autoantibody, which is a myositis specific antibody, anti-TIF1 gamma, was detected in this patient. So try to remember this, that the autoantibody which was detected in this patient was anti-TIF1 gamma, and we'll come to it later. So the final diagnosis in our patient was based on characteristic clinical features, a long-standing disease, rash, fever, inability to stand from sitting position, in presence of elevated muscle enzymes, characteristic MRI findings, and positive myositis specific autoantibody. So the diagnosis is very clear, very certain, juvenile dermatomyositis. We may not find it as easy in many of the situations, but it is not always very difficult to diagnose these patients if they have characteristic dermatological manifestations. Now, what are these myositis-specific autoantibodies and myositis-associated autoantibodies? They have got an increasingly important role in diagnosis of juvenile dermatomyositis and even in the management of juvenile dermatomyositis. So we must know a little bit about myositis-specific autoantibodies. So they are myositis specific and another group which is called myositis associated autoantibodies. As the name suggests, myositis specific autoantibodies means they have got a very high specificity for inflammatory myopathies. That means that if they are found, the diagnosis is almost certain. They are specific for inflammatory myopathies and not seen in other group of connective tissue disorders. The common myositis specific autoantibodies which have been described, there is a list of myositis-specific autoantibodies. I'm going to describe only those which are commonly seen, which are of high clinical relevance. So the common ones are anti-TIF1 gamma, like it was seen in our patient. Then is anti-NXP2, anti-MDA5. I would urge the residents to remember at least these three: anti-TIF1 gamma, anti-NXP2, anti-MDA5. Interestingly, the myositis-specific autoantibodies have a certain phenotypic correlation, and certain clinical features are associated with specific myositis autoantibodies. So anti-TIF1 gamma is associated with severe cutaneous disease. Anti-NXP2, another important autoantibody, is associated with a complication which is calcinosis cutis. Also, GI ulceration is more commonly seen in patients who have anti-NXP2 positivity. Anti-MDA5, another very important, it has got a very high clinical relevance or prognostic relevance, I would say, because it has got a very strong correlation with development of interstitial lung disease and sometimes rapidly progressive interstitial lung disease, which can even take the patient away from us. The other myositis-specific autoantibodies have also been described to have some phenotypic correlation. But again, I would suggest that at least these three, anti-TIF1 gamma with cutaneous disease, NXP2 with calcinosis, MDA5 with ILD, we must try to remember them. So these are the phenotypic correlations where you can see this is our patient and who is anti-TIF1 gamma. And even on follow-up after 2.5 years, she continues to have these cutaneous manifestations. This is also a cutaneous manifestation called linear extensor erythema, which is seen in this patient. Anti-NXP2, if you can appreciate over neck, this is the calcium deposit, and these are the calcinosis nodules. In MDA5, we will see interstitial lung disease. There are some myositis associated autoantibodies as well, which means that they are also seen in other pediatric rheumatological disorders, but also seen in myositis, and they're commonly described like polymyositis, SCL, anti-CoO, anti-RNP, Rho52, and there is a list of other myositis associated. Essential point to remember is that there are two groups of autoantibodies. One is myositis specific, one is myositis associated. We looked at autoantibody profile of children with juvenile dermatomyositis back in 2017 to 19, and we found that ANA positivity was seen in 43% of children that we studied, and myositis specific autoantibodies in nearly 1/4 of them. Interesting points to know are that myositis-specific autoantibodies are said to be mutually exclusive. That means you are likely to find only one myositis-specific autoantibody in a given child. Myositis associated, you can have more than one. In the follow-up in our patient, she continues to have these dermatological manifestations, even the heliotrope rash. And as we know that she was anti-TIF1 gamma positive, we expect this to be there. How do we treat juvenile dermatomyositis? So treatment of juvenile dermatomyositis essentially consists of immunomodulation. Corticosteroids are given to all the patients in whom we diagnose juvenile dermatomyositis. We start with intravenous methylprednisolone pulse in a dose of 30 mg per kg per day with a maximum of 1 gram for 3 to 5 days, followed by oral prednisolone in tapering doses. So we give full dose oral prednisolone for 4 weeks and then we decide about tapering. Along with corticosteroids, we start all of them after obviously the baseline screening. We start all of them on subcutaneous weekly methotrexate, and I'm sure now almost all of us will remember the dose of 15 to 20 milligram per meter square per week. And some additional therapies like hydroxychloroquine, photoprotection, calcium, vitamin D are also administered to these children. So essentially, this is what consists of treatment of juvenile dermatomyositis. So we give, as I said, we give oral prednisolone in full dose for 4 weeks, and at 4 weeks, we see the patient. If the patient is improving, we start tapering prednisolone and taper it over 12 months. So these are a group of disorders, all the rheumatological disorders, where corticosteroids are given for a long duration. So we start tapering prednisolone and taper it over 12 months. If the disease is static, means the patient has not shown any improvement, we continue same medication for another 4 weeks and then again reassess if the child is improving or static or worsening. If the child is worsening after 4 weeks, then we consider additional therapy. Now, what are these additional therapies? The additional therapies most commonly used, most often used in our setup is cyclophosphamide, which is given as we give it in systemic lupus, in pulses, intravenous, monthly pulses. The other options are mycophenolate mofetil, which is available in oral form, intravenous immunoglobulins. Interestingly, intravenous immunoglobulins are increasingly being used in patients with juvenile dermatomyositis for different kinds of manifestations. So there are patients who have predominant cutaneous manifestations in terms of, Gottron papules or different kinds of rashes like malar rash, Scholl's sign, heliotrope rash, but they do not have much of muscle weakness, which is also called clinically amyopathic dermatomyositis. Amyopathic means muscle involvement is not that predominant, but cutaneous manifestations are a trouble for the patient. So for cutaneous manifestations also, it has been shown that intravenous immunoglobulins work very well. The regime for intravenous immunoglobulins for juvenile dermatomyositis is giving it every month. So intravenous immunoglobulins are increasingly being used in management of juvenile dermatomyositis. The other drugs being rituximab and drugs like cyclosporin. There are some newer modalities available. We all know that JAK inhibitors are finding a place in pediatric rheumatology as well. And now there are many conditions in which we use JAK inhibitors. The advantage is that they're orally available. So different kinds of juvenile arthritis. So there is also a place of JAK inhibitors in management of juvenile dermatomyositis. Then CAR T cell therapy is upcoming in a big way for management of juvenile dermatomyositis as well. People have even done a stem cell transplant for juvenile dermatomyositis. So this was about a routine, a usual case of juvenile dermatomyositis who comes to us. We diagnose based on characteristic clinical features, elevated muscle enzymes, myositis-specific autoantibody, MRI. We start treating the child with the conventional kind of therapy for juvenile dermatomyositis, and she shows an improvement. Coming to the final and next case, which is a diagnosed case of juvenile dermatomyositis. So this is already diagnosed, 8 years boy, doing well on treatment, which is oral corticosteroids and subcutaneous methotrexate, along with the additional therapy of photoprotection, vitamin D, hydroxychloroquine, calcium. However, parents stopped giving oral corticosteroids after 8 months. As the child showed improvement, they stopped giving it and the other kinds of therapies. After stopping treatment, the child remained asymptomatic for a year. However, 18 months later, after diagnosis and initiation of treatment, the patient again presented to us with this. So he was not having much of muscle involvement or muscle weakness. However, he developed these kinds of lesions over abdomen, back of thigh, the popliteal site, and over the back, lower back. So these are calcium deposits or calcinosis cutis. Some places where it was not evident was picked up on X-ray as well. So if we are able to palpate them, we don't need to do an X-ray, but these X-rays also show these calcium deposits. So you can see calcium being extruded from these lesions. So there is a variety of calcinosis cutis that can occur in these patients. This is one type of them. So there are certain complications that one must be aware of. Calcinosis cutis is I would say one of the most common, one of the most prominent complications that we have seen. And at times it is really troublesome, with patients being turned into sheets of calcium and not being able to move at all. We also saw that occurrence of calcinosis is highly associated with NXP2 myositis specific autoantibody. So I hope now the residents will remember that calcinosis, if we find NXP2 antibody, we know that this child is highly likely to have calcinosis. The use of myositis specific autoantibodies is there for the last few years only. So earlier we didn't know there was any association, but now at the time of diagnosis, we can get the autoantibody done and we can predict that this particular child is likely to have calcinosis. So calcinosis is one of the most common, I would also say a dreaded complication. It is not life-threatening, but the quality of life is affected in a big way if there is calcinosis. Other complications being lipodystrophy, loss of fat, subcutaneous fat, hirsutism in females, and interstitial lung disease. As we have already discussed in those with MDA5, it is a dreaded complication. So these are the complications I've tried to show. This is calcinosis. And if you see at this is a young girl, excessive hair growth along with loss of subcutaneous fat over thighs as well. So this is a girl who had all these complications in form of calcinosis, excessive hair growth, as well as lipodystrophy. And it is also seen that these complications are more likely to develop if there is a delay in diagnosis and initiation of treatment. Though they cannot be prevented at all, but it has been seen that if there is a delay in diagnosis and initiation of treatment, they are more likely to occur. Our patient of calcinosis, we started him on treatment with intravenous immunoglobulins and some other drugs like diltiazem. Bisphosphonates are also given for it. After treatment, he has shown some improvement. Calcinosis over lower back has disappeared, and these have decreased in size. What is the long-term outcome of patients with juvenile dermatomyositis? When the treatment was not available, even in the form of corticosteroids, it was said that 1/3 of them died. 1/3 of them had chronic complications, and only 1/3 of them had good outcome. With the current available treatment, the good functional outcome is up to the tune of 80%, and around 25 to 30% are likely to have minimal dysfunction in the form of atrophy or contractures. Calcinosis, as we have seen, it has been seen in up to 50% of them in various studies. So it is highly prevalent in these patients, calcinosis. Now, with the current available treatment, with the availability of myositis-specific antibodies, we believe that the occurrence of calcinosis is likely to decrease. Then functional disability is seen in some, and mortality now is up to 1 to 2%. There are three types of outcomes. One is monocyclic, where the patient has disease, is treated, and is cured of the disease, is in remission forever. So this is called monocyclic disease. This occurs in about, we try to remember it like 1/3 course in every type of course is seen in about 1/3 of patients. So chronic cutaneous course is, despite treatment, the patient continues to have some disease activity beyond 2 years. This is called chronic continuous. Polycyclic is when the patient goes into remission, but again has that disease. This is polycyclic. So combined chronic cutaneous and polycyclic is seen in around 60% of them. We also looked at long-term outcome in children with juvenile dermatomyositis from North India, from PGI. We enrolled patients with a median disease duration of around 7 years, 73 months, and the range was 2 years to, you can see 219 months, which is more than, 18, 19 years. So this was a wide range. This was a study where we used validated outcome measures to look at the long-term outcomes. Interestingly, we found that more than half of them had ongoing cutaneous activity in some form or the other. Like some had Gottron papules, some had this linear extensor erythema, and nearly 2/3 had damage, permanent damage, in some organ. The some organ may even be muscle, joint, or any other organ system. So long-term complication, long-term outcome is not that good. But the study was done again in around 2017. So with the current treatment modalities, with the current diagnostic facilities that we have in terms of MSAs, the long-term outcome is likely to improve. So we learned that juvenile dermatomyositis is not though common. The incidence is about 2 to 4 children per 1 million children. So it is though not very common, but it is commonest inflammatory myopathy of childhood. Not difficult to diagnose if there is presence of characteristic dermatological manifestations. One may have to carefully look for them. With characteristic symmetrical proximal muscle weakness, we also understood that though there are classification criteria, we may not need to do muscle biopsy and EMG in all of them. Sometimes what happens is we look at the criteria and we try to get those criteria fulfilled. But we do not need to do the muscle biopsies in them if we have characteristic clinical features or characteristic muscle enzyme elevation. MRI, as we understood, is helpful for diagnosis. There are characteristic findings in terms of symmetrical T2 and STIR hyperintensities with subcutaneous edema. Myositis-specific autoantibodies, if they are available where we are working, they are extremely helpful, increasingly being used for diagnosis, and as we understood, also for characterization of the disease. But again, we must not wait for MSAs to be detected, or we must not wait MSAs to be sent before we decide upon treatment. Diagnosis of juvenile dermatomyositis can very easily be made without myositis-specific autoantibodies. But if they are available, yes, they can help us in a big way. We also learned that long-term complications do exist, and if there is a delay in diagnosis, delay in initiation of treatment, one is likely to encounter these complications. One must be aware of these complications like calcinosis, lipodystrophy, interstitial lung disease. So when one knows about these complications, one is always watchful for them. I hope I was able to bring out the facts regarding the commonest of inflammatory myopathies, though not very common, but we do encounter these cases, and if managed properly, we can prevent the complications, morbidities, and even mortality. Thank you so much.
Thank you. Thank you, Dr. Avinash Sharma, sir. You have beautifully elaborated the juvenile dermatomyositis by presenting two different cases. Very interestingly, we should understand newer modalities are present to diagnose. So 100% autoantibodies cannot detect the diagnose 100% the dermatomyositis. The MRI will also be very useful. 20% may
Stop sharing the screen.
escape
Yes,
the
I'm trying
diagnosis.
yeah.
Yes, sir. Sir, can we have this any nerve conduction study? Is it useful in diagnosing myositis?
Okay. So nerve conduction studies, interesting question, but nerve conduction studies, we will perform only if we are in doubt that this is this a muscle disease? Is it a myopathy or a neuropathy or a nerve kind of disorder that we are considering? So as I explained and I tried to highlight time and again, if we have those characteristic dermatological features, the Gottron papules and heliotrope rash, there are some other cutaneous manifestations as well, which I have not elaborated into, like the malar rash. It is somewhat different from SLE. Then there is shawl sign, rash over the area where shawl is worn, linear extensor erythema. So if there are these cutaneous features, we need not go ahead with the nerve conduction studies or CSF. If the DTRs are
it may be
intact and we are
typically
sure
normal.
that yeah.
It may be typically normal in dermatomyositis.
Yes.
We should
Yes.
not rely much on the nerve conductions. Sir, we understood by in your session that the dermatomyositis may occur without muscle involvement also,
Yes.
that we call it as amyopathic dermatitis.
Yes.
Can
Yes.
we have reverse without dermatology, without dermatological involvement, only myositis.
A very interesting and important, very interesting observation, I would say. Yes, then the disorder is not known as dermatomyositis. Uh, as I said, this is the commonest of inflammatory myopathies. So we can have inflammatory myopathies which are not dermatomyositis. So if we do not have dermatological findings, then the condition is not dermatomyositis. It may be something
Yes.
called polymyositis. So polymyositis
Yes.
is a similar condition. Myositis specific autoantibodies are also seen in polymyositis. It is managed in more or less same way, but you do not find dermatological manifestations. And because you have brought up this point, I would also like to highlight that this is a situation where you would do investigations like EMG and muscle biopsy.
Yes.
Because you do not have the typical cutaneous manifestations. So if we try to visualize, what will the patient present with? Only symmetrical proximal muscle weakness. So there can be a list of causes for that.
Yes.
As far as the inflammatory myopathies goes, polymyositis is most important amongst them. So to diagnose polymyositis,
Correct.
if MSA is not there, we need to do a muscle biopsy. We need to do even EMG. So these are invasive investigations. But then the disease does not remain dermatomyositis. Yeah.
Yeah, but what we have to remember is all the skin manifestations may not be present.
Yes. Yes.
All the cases may not have heliotropic rash.
Yes.
Some have,
Yes.
all the may not have cotton papules.
Yes.
So that we need to remember.
Yes.
So in the evaluation.
Yes. Yes.
Sir, in the management side, we understood the myositis management. Is there any management for the dermatological manifestations?
There are. People do use topical, medications like topical corticosteroids, tacrolimus. But as I said, there are a group of researchers who are looking only at a specific manifestation of the disease. So there are certain groups who are looking only at dermatological manifestations. So predominantly, it is seen that intravenous immunoglobulins work very well if they are predominantly cutaneous manifestations. Monthly infusion of intravenous immunoglobulins. We are also giving to some of our patients.
What we are
please.
remember.
Your voice is cracking.
Yes, you are not clearly audible.
I think
very sensitive to ultraviolet be used.
Pardon, I didn't get it.
Can you hear me?
Yeah, your voice is cracking, Dr. Nandish.
Ultraviolet light. Any role of ultraviolet?
I'm not aware of any. In fact, ultraviolet light is said to trigger these kind of disorders.
Switch off video. Yes.
Yeah.
Yes. Yeah. Thank you very much, sir. Thank you very much for guidance.
Thank you.
We welcome Dr. Pankaj Garg, President IIP Delhi.
And sir,
yeah, thank you. And I'm sorry that I joined little late. We are celebrating World Health Day today at Japanese Park, which is close to our place in Rohini. So that is why I joined late. But I welcome Dr. Ramesh Bajania, sir, the CIP West Zone Vice President, and Dr. Nandish, CIP EB member from Karnataka, and of course, Dr. Bennett, who has become a regular with us, CIP member from Kerala. So I welcome you all. And an excellent talk, Dr. Avinash. I listened to most of it except the first 10 minutes. So it was a very interesting talk. In my whole practice of 30 years, I only seen one case of dermatomyositis. So definitely it is not very common.
Not very common, yeah.
But one question which always bothers me, and which I, being a senior person, I want to ask you, that there are a lot of rheumatological disorders, and but the time at which they present is very varied. Like SLA is present in adolescent age, Kawasaki presents at less than 5 years, GI presents early, psoriatic arthritis, dermatomyositis. Everybody, all of them are rheumatological. All of them have autoimmune phenomena. So why the age of presentation is different? And usually, if you see pediatric as a whole group, it is less common. The rheumatological disorders present little late. So what is the thinking behind it? What's the logic behind all this chronology of rheumatological disorder?
Again, an interesting question, sir. As We all know that the typical answer जो हम लोग question answer theory paper में भी लिखते हैं, what is the cause? They occur in genetically susceptible individuals when they are exposed to certain triggers. So it is believed that those which occur at a younger age, like we can say Kawasaki disease, they occur at very young age. So they have a strong genetic predisposition. Whereas conditions like SLE, they occur when they are exposed to certain environmental triggers for a certain period of time. So they take long, especially autoantibody mediated diseases. Those which require autoantibodies to be produced, they take some time, some exposure before they are produced. So typically you will find the autoantibody kind of diseases, they occur typically late over adolescence. And those that occur in younger age, they have stronger genetic link. People have studied genetic links for almost every kind of rheumatological disorders. Even in juvenile dermatomyositis, they said there are certain genes, HLA and non-HLA genes. So if there is specific genotype is there, they are more likely to have juvenile dermatomyositis. So if there is a presence of these the well-defined genetic predispositions, then they are more likely to get these disorders in younger age group. We also know, we listen to the SLE class, we know that there are monogenic forms of these disorders as well, where there are defined genetic mutations which result in these disorders. If the disease is monogenic, very well defined genetic, then they tend to occur in a younger age group, very young age group. But if there is no well-known genetic predisposition, and if it is depending only on the environmental triggers, it takes some time for them to develop before they are exposed to a certain extent, to a certain dose of that trigger before the disease manifests. So this may be one of the hypotheses, not very clearly known. We also know that pubertal hormones also play some role in causation of these disorders. So it is only after puberty that these disorders occur. So there are many factors, but this is one of the hypotheses that we can
So it's
think.
very interesting, which as a very interesting explanation. At least it explains a lot of things about at least Kawasaki SLEs, which are the common prototypes. So if it's the environmental trigger, which is the most important thing in those disorders which manifest later, but if you change the environment, you does it matter? Because we say it's a lifelong disease, you
Yes.
take lifelong treatment. So, but if you change the environment, you go to some other place, does it help?
Again, interesting, like we know for SLE, I'll take the example of SLE. We know that we ask the patients to avoid sunlight. That is an environment change because that is the definitive trigger that we know of. जैसा मैंने पहले बोला, हम एग्जाम में यही लिखते हैं in the presence of genetic susceptibility, exposure to certain triggers. No one knows those triggers. Very well-known trigger is the ultraviolet radiation from sunlight. So we try to change the environment by asking the patients not to get exposed to sunlight, to use photoprotective measures like use of sunscreens, umbrellas, full sleeve clothes. So that is a change in environment. Yes, if you ask the dermatologists, now they believe that use of photoprotective measures are to be used by all of us. Like we pediatricians believe that vitamin D सबको ही देना चाहिए infancy में, vitamin K सबको देना चाहिए. It is not only the patients. They are preventive measures. So dermatologists will say that use of sunscreen or photoprotective measures should be universal. That is a kind of preventive strategy to prevent many of these disorders because it is a well-known trigger for many autoimmune disorders, including juvenile dermatomyositis.
Thank you so much. Thank you so much. And I'm sure
Request Dr. Ramesh Bajania sir to please say.
please.
To this discussion, a lot of these triggers are viral infections also. I'm sure sir would agree with this. Like Kawasaki and systemic GIA, we see seasonality in them. Post winter break, post spring break, when the viral infections increase, and a lot of studies have been conducted in Japan on this as well.
Very interesting observation. Thank you. Dr. Ramesh sir.
Yes, good morning, Pankaj
Forward to
sir.
your comments.
Yeah. No, it was a really very comprehensive, lucid, and clear discussion about the topic. And as you said, it is very rare. But for the family, if a child is having such problem, then for them it is the entire world. So for us, it might be rare. So I'm very sure that this very interesting deliberation must have sensitized the viewers, and hope in the next patient they will not miss. The primary purpose of such type of discussion is basically to sensitize. They might not be able to treat, but earlier they detect, the lesser the morbidity. So congratulations, Delhi branch, for this wonderful activity, and wish you all the best for future endeavors too. Thank you so much for this opportunity.
Interestingly, Dr. Bajania sir is part of the environmental group and is working very passionately to improve the environmental.
So I think that is one of the most important things which we need in our country.
Dr. Dolly, are there any questions?
Yes, sir, there are some questions.
Yes.
Sir, if a child presents with viral fever associated with muscle pain, unable to walk, CPK was 40,000 and it got settled and normalized in 10 days. After 6 months presenting with on and off muscle pain, especially calf, and the child is unable to walk unaided, should we suspect rheumatological problem in this child?
I would say it is a rather common occurrence. We all encounter such children. And I would also say that it is not once, but more than once that we have also burnt our fingers in terms that we started evaluating the child for rheumatological disorders and we did not find anything. I can remember patients where we even counseled the parents that this is a long-term disease, this is likely to last for very long. And then few days later, the family found us in some market, the child playing around. So often the viral myositis kind of thing does not evolve into rheumatological disorders. Yes, if the condition persists for more than few weeks, as we discussed, juvenile dermatomyositis, as we saw in our patient, had symptoms lasting for a few months. So I would say if the symptoms persist for more than few weeks, I would say more than 2 to 3 weeks, if the pain persists or inability to stand from sitting posture, then we can start thinking about rheumatological disorders. And when we start thinking, that means we should start looking for other clinical signs. Before we start investigating the child, it is important for us to look for those subtle clinical signs, look for those dermatological manifestations. And if you're thinking of some other rheumatological disorder, try to look for clinical signs. Try to find the clues from very basic of investigations like hemogram. As we have been discussing throughout the previous discussions, even hemogram give us very important clues. So it is not always that if you find a child who is having pain in the calf, is unable to stand from sitting posture, that we start sending the very specific investigations for rheumatological disorders. But if the symptoms persist and if you find any clues, then you start investigating the child for rheumatological disorders.
Thank you, sir. Sir, there is another question asking about the treatment of calcinosis.
So treatment of calcinosis can be another session. As I briefly mentioned that calcinosis is treated in multiple ways. One way is to, upscale the immunomodulation that you are doing, like increasing the dose of corticosteroids or giving another additional therapy in the form of cyclophosphamide. But typical treatment for calcinosis is use of drugs like diltiazem, even intravenous immunoglobulins. And then we very often use bisphosphonates like pamidronate. And there are some specific therapies also which are available like sodium thiosulfate. But these are all very specific treatments for calcinosis. So I can say that treatment of calcinosis or calcinosis in itself can be a very long session for discussion.
So
Thank you, sir.
may I take this opportunity
Yeah,
to
sure.
discuss about calcinosis?
Sure.
Actually, we also have a couple of patients, and after trying everything in them, one of them is NXP2 positive,
Yeah.
and she has extensive cutaneous calcinosis extending all over the body. I have given pamidronate, tried diltiazem, MMF, and now I have finally shifted her to tofacitinib. What is your experience? Does this actually...
As I stated in the presentation as well, yes, calcinosis can be very troublesome. You already know that we have seen patients. I can recall a patient who is bedbound because he has sheet-like calcinosis. He cannot move his limbs at all,
Yes,
not
exactly.
because of muscle weakness, but because of the calcinosis that he has. We also have been trying whatever you have done, like diltiazem, changing the drugs from cyclophosphamide to mycophenolate mofetil, even JAK inhibitors. Sometimes nothing works. When we discussed it with some experts of calcinosis, they say sodium thiosulfate intralesional can be tried, which we have never tried. What I have found is that there is no single answer for this, but some children, some patients respond very well to therapies that we give, even intravenous immunoglobulins with diltiazem, some to bisphosphonate, but some patients refuse to budge at all, and their calcinosis does not change its position at all with whatever kind of treatment that you give. So calcinosis is a challenge in these patients.
There's one more question. Would like to know if the child has disease onset, what is the time duration approximately within which cutaneous manifestations occur?
So cutaneous manifestations are often the first manifestations before muscle weakness appears. It is not a rule, but it is often the cutaneous manifestations that we look for whenever the patient comes with the proximal muscle weakness. So it is usually the first sign that is seen. So as I said, they may have to be looked for carefully. One may miss the heliotrope rash, and if not looked at carefully, one may even miss the Gottron papules. And Gottron papules are not only seen over the hands, they can also be seen over elbows, ankles. So they have to be looked for.
We welcome Dr. Shyam Meena, Secretary, IP Delhi. And I request Dr. Bennett Xylem sir to please say a few words, and then I'll request Dr. Shyam.
Okay, thank you very much, sir, for this opportunity. It's an interesting topic. So that's the reason I am joining regularly. And sir, around that I got some doubts. Like already I posted. Anyway, I will spell it out. So one doubt is how we can taper the steroid over 12 months, because 12 months is a very long duration. Is it a weekly based tapering or monthly based tapering? Each tapering, how much dose you can reduce? It is a 5 milligram, 10 milligram, it's like that. So how you are going to taper it? Because the time duration is very high.
Yes. So as we must have seen in the previous sessions as well, in rheumatology, as I said, that the duration of corticosteroids is very long. There is no rule. You can find guidelines from CARA or groups like that, but there is no single rule for tapering of steroids in which applies for all. So it depends upon patient to patient. Suppose a hypothetical situation, suppose a patient who has been initiated on 50 grams of prednisolone per day.
Okay.
With 2 mg per kg. We give it for 4 weeks. Now I plan to taper it in next 12 months. So I know that 50 grams has to be brought to 0 in next 12 months. So I plan in such a way that suppose I bring it down by 5 milligram every month, I'll be able to bring it to 0 in next 10 months. I want to extend it to 2 more months. So what I'll do is when I reach 10 mg, I'll extend the period to 6 weeks. Then 5 mg. Then we even do alternate day therapy in the end just to extend the period. So, suppose I reach at 5 mg.
Okay.
What I'll do is 5 mg one day, 2.5 mg another day, 5 mg, 2.5 mg. Then probably 2.5 mg every day, 2.5 mg alternate day, just to prolong the treatment. So we plan every patient. And it is not a uniform formula that you reduce by 25%, unlike what we do in nephrotic syndrome, where there are very set guidelines.
Yeah, 6 weeks, 6 weeks, and
Yes.
6 weeks. Like that. Okay. Another question is for biopsy. You said that if you do a biopsy from a muscle, sometimes you may not find any lesions.
Yes.
Suppose if you do a biopsy in like Wharton papules or a heliotrope rashes, is there any chance of getting some positive finding?
And interestingly, I wanted to share this screenshot from a mail which was posted in a group yesterday. Somebody asked this question: do you biopsy the skin lesions of juvenile dermatomyositis? So a dermatologist from US, she said, I have never biopsied a cutaneous lesion from juvenile dermatomyositis. She said that it is not required at all because they are very characteristic. But I would add that usually we do not skin biopsy children with dermatomyositis. Inflicting a lesion, an injury, may also predispose them to develop calcinosis in those sites. And it will not be helpful if we biopsy those lesions to diagnose. Physically, they are very characteristic if you look at them. So it is not likely to miss them.
Okay. Okay, so thank you very much. It's an excellent talk. Very interesting to hear. Thank you.
Thank you.
Thank you, Dr. Bennett, and
Thank you for joining all the
we
sessions.
like your presence and we like your questions also.
And I request our secretary, Dr. Shamina sir, to please say a few words and put a vote of.
Good morning, everyone, and thanks to Avinash Sharma sir, such a lucid presentation. He's tried to cover the all very important things in this single session. So that session is very informative. I have the small query about your presentation. What is the long-term outcome, especially what are the things that change over the treatment of the dermatological complications? That maybe create some cosmetic issues or might that. So what are the outcome of that, especially dermatological conditions in dermatomyositis?
We have group of patients who are really worried about cutaneous manifestations. As you said, there are cosmetic concerns for some. They are like calcinosis. They are not as troublesome in terms of the systemic involvement or daily functioning, but sometimes cosmetically they can be very troublesome for the patients if they have heliotrope rash or even Gottron papules, even though they are not very visible. But if the patient has those Gottron papules and the family is daily looking at them, they find that they're not disappearing at all. Now we know that there are a group of myositis-specific autoantibodies that are associated with ongoing cutaneous manifestations. There is no definitive treatment for cutaneous manifestations, but as I said, there are very well-known groups of workers, researchers, who are working on dermatological manifestations, and the most effective treatment according to them is intravenous immunoglobulins. We have also tried in our patients who insist. I would say, it may be my personal opinion, I would say that dermatological manifestations we tend to treat if the patients insist. For us, it may not be significant at all, but we don't know if it is associated with systemic manifestations. They may not have obvious muscle weakness or obvious organ involvement. So we try to pass it off like that, कि ये सिर्फ skin पे ही है तो कोई ज़्यादा issue नहीं है. But if the patients insist, we do treat, and we have patients in whom we are giving monthly IVIG, which is making some difference. Photoprotection is of extreme paramount importance, which they should adhere to very religiously. They can also help. Then there are some topical medications like corticosteroids and tacrolimus, which also sometimes help, but not a definitive answer.
Okay, sir. Thank you.
Thank you, Dr. Meena sir. I thank Dr. Avinash Sharma sir and the chairpersons, Dr. Nandish sir and Dr. Ramesh Bajania sir, for chairing this session, and also Dr. Dolly Madan and Dr. Neha Mehra for coordinating all the sessions, and Dr. Pankaj Garg for joining in, and Dr. Shamina sir. And thank all the delegates for joining in. We'll be sharing the recording soon, and we'll meet on the next Sunday at same time, 9 o'clock. Thank you very much.